Welcome everyone to our first webinar for the Canadian Health Workforce Network in our new season of 2023-24. And I'm super excited to have our three guest speakers with us today, colleagues from the United States, providing us with some background in terms of some promising practices in the US. I will start first by introducing myself. For those who do not know me, I'm Ivy Bourgeau. I'm very pleased and privileged to be the lead of the Canadian Health Workforce Network, and very pleased and privileged to be a colleague with our presenters today. I first of all, after introducing myself, want to acknowledge that I am coming to you from unceded, unsurrendered territory of the Algonquin and Anishinaabe First Nations people. We are gathered here virtually, and so many of you are coming from other territories of First Nations, Inuit, and Métis people. We at the Canadian Health Workforce Network want to undertake the work of reconciliation as has been outlined in the calls to action of the Truth and Reconciliation Commission. And we recognize that acknowledging land that we are coming from is only one small part of responding to the calls to action. And later on this month, we will be taking time to reflect on the issues around reconciliation, and particularly remembering the legacies of the residential school system on September 30th. So just wanting to acknowledge that. All right. With that, and I see many more of you have joined us, which is great. I just ask everybody to stay on mute. I think you come in with your mics on mute, and please keep them on mute. Please feel free to introduce yourself in the chat. You can acknowledge territory that you're coming from. And I will be monitoring the chat, and I do want you to be utilizing it for comments or questions for the speakers as they go through. The run of show is that Michelle will lead off, followed by Erin and Bianca, and they will each introduce themselves. And with that, I will pass over to Michelle. Welcome.
Thank you so much. And I will move to share my screen here. I do have a small presentation to help guide. There we go. And hopefully everyone can see this. Thank you again. I'm very pleased to be here. My name is Dr. Michelle Washko. I'm the director of the National Center for Health Workforce Analysis. We are within the U.S. Department of Health and Human Services, which of course is the lead for health and human services for the federal government in our nation. And what we are is a national research center focused on the health workforce. And what I'm going to talk about today is really going to set up Dr. Fraher and Dr. Frogner for their presentations, as they're going to go a bit more topical. So our mission, as established by the U.S. Congress, is to support, as you can see, informed public and private sector decision-making. And we do that for the health workforce and health support workforces and public health workforces by expanding the evidence base around these labor force collectively. Our primary objective to support that mission is really to produce, meaning actually generate research, to fund research, and then disseminate it widely, not just research findings, but data as well on the U.S. healthcare and health support workforces. So we meet this objective through 5 kind of strategic actions, one of which will be the focus of all of our discussions today. First, we actually conduct intramural research on the healthcare workforce that we then publish publicly for the world to see. And that is generated internally by staff here in the federal government. The second thing we do, which is really where our focus of today's comments will be, is that we fund extramural research on the health workforce in the U.S., meaning we are appropriated dollars by the U.S. Congress, which we then turn around and give out competitively to consortiums and universities and eligible entities to conduct in-depth research on cutting-edge issues in all sectors of the U.S. healthcare system. We are also legislatively tasked with figuring out the adequacy of the health workforce in the U.S. So really, do we have enough and of the right people? We evaluate federal health workforce development programs. So again, Congress gives HHS money billions and billions and billions of dollars to help educate, train, and retain health workers at large. And we evaluate how that funding is working. And then we disseminate all of this, meaning we put it out there for the world to see and to digest and to use. In terms of our, we have two branches in our National Research Center. Our Workforce Analysis branch is where our Health Workforce Research Centers live. That is the bulk of our funding goes out to these HWRCs to conduct in-depth and cutting-edge research that perhaps the federal government doesn't have the bandwidth or the infrastructure or the funding to conduct. We also produce, as I mentioned, intramural research, and you can see all of the kinds of things we do on the right-hand side of this slide. We put out things like actual forecasts for occupations in the US. Will we have enough in 15 years? We purchase data and then turn around and aggregate, disaggregate, and manipulate that data and put out actual public use files of data. We do that, our kind of gold standard, our keystone, capstone of all of that is the National Sample Survey of Registered Nurses, which is a one of its kind survey here in the US on what is our largest health profession, and we turn that around every 4 years. We also serve as a point for the federal government to report out to international entities like the World Health Organization. So that's the kind of things that come out of that particular branch. We do have another branch. This is our performance measurement and evaluation branch. If you recall on my earlier slide, the 5 major activities we undertake to meet our objective. This is the branch that is focused on evaluating, engaging the program performance of the billions of dollars of health professions, education, and training dollars that the US government puts out to all sorts of entities, states, universities, trade associations, and others. And they're really focused on figuring out the sufficiency, the distribution, the access, and the quality, and what those large amounts of taxpayer dollars are doing in those areas as it relates to the workforce. As I mentioned, the focus of today in our discussion in this webinar is really the work that our Health Workforce Research Center program, how it is structured and what it does. And you'll hear from my colleagues on some of the wonderful work that they do and where they're focused. So you can see our statutory purpose is really to, for these centers, is to collect, analyze, and report health workforce data to my national center, but also turn around and use that information to help state, local, regional, and other entities on understanding all of it as well. The history of the program is longer than it seems. It actually was originally funded about 20 years ago, give or take. And then over the course of various presidential administrations was allowed to lapse. The National Center was codified in the Affordable Care Act, and the program was reestablished and appropriated. We have since implemented 5-year cooperative agreements. This is a form of a grant where the US federal government, it's not quite a contract, it's not quite a grant. It's a medium, a happy medium, I like to think of it as, where we're giving out grant dollars to eligible entities like universities and colleges. And we, the federal government, have some substantive say in what they do. We don't control all of their products. We certainly don't control all of the research that they do, but we get to speak up and have a voice. And it's also not as restrictive as a contract where we would be specifically saying you must produce X, Y, and Z. Over the course of the past decade, we have really grown as the importance of the healthcare workforce in the US has grown in importance, and people recognize that. We started with funding just 4 centers, then it was 6, then it was 7, and now we're up to 9, which is fantastic, especially given their 5-year cooperative agreements. That really allows, I think, an entity, a consortium, a university to really develop a full research profile that can help all stakeholders and decision makers use that information over a period of time. The core activities that these centers engage in, they produce for us, and their base funding, 4 annual research studies per year. We often give supplemental funding to purchase, if you will, more research studies. And as I was saying about this cooperative agreement structure, studies may not be for the federal government, Health and Human Services, but they can certainly relate to our interests. And I think we've established a really nice rapport between the National Center and these awarded HWRCs over the years, so that everybody's needs and interests are getting met. They also produce rapid responses every year. These are smaller in scope than annual research studies and may or may not be suitable for publication. I mean, I think, a standard research study is the kind of thing you go out, you conduct you have your scientific question, you conduct your analyses, however, whether it's quantitative or qualitative, and then you have some sort of a paper, a report, findings at the end, a visualization tool. The rapid responses are not that. They're actually a lot smaller in scope, and they're really on very specific topics. This is just a slide that shows some recent topics, research studies that we, I guess you could say, commissioned from our HWRCs over the past couple of years. These are mainly since the COVID pandemic. So you can see we asked for research to look at strategies that support and prevent burnout amongst low-wage frontline workers during the pandemic. So a little bit of a retrospective look. We were looking at, in the US, a big topic right now, of course, is maternal health care. So we funded some research centers to do projects around things like doulas or telehealth, whether that's teledentistry, telehealth, telebehavioral health. We paid for some studies that look at geographic distribution of providers. You can see an example here, one in behavioral health. We also look at things like wage variation and diversity and health equity, which is very important right now. So these are just examples of some of the annual research projects that have been conducted in recent years. And then what we really do, at least at the National Center, is then the US government takes what these wonderful research centers are doing, because we're investing money. This is the federal government, Congress, investing taxpayer dollars in applied research. So it is incumbent on the National Center then to take the information that the HWRCs generate and then leverage that to figure out what our policy priorities should be. How can we best give technical assistance to Congress as they're developing legislation, as they are funding things, and to do this from a scientific perspective, so that it's really these decision makers are able to make their case based in data and research. And this last slide just shows who our current HWRC awardees are. Of course, Dr. Frogner will be speaking in terms of our allied health as well as our health equity center, and Dr. Fraher will be focusing, I believe, on our emerging policy center, and they have our newly awarded behavioral health center. And Ivy, you're welcome to have these slides and distribute. All of the links are active so people could connect to all of these places. But with that, I will stop. Again, I'm not going in depth on all of the work that we do, but now I will turn it over to Dr. Fraher, I believe, is going first, to talk about what her center does and give you a bit more detail. So thank you so much.
Thank you so much, Michelle. It's a pleasure to be here, and I will go into presenter mode. Well, hello, everyone. I'm Erin Fraher. I'm a professor in the Department of Family Medicine at the University of North Carolina at Chapel Hill, where I also direct the Carolina Health Workforce Research Center, and I'm going to talk to you a bit about that. But most importantly, for this audience, my career in health workforce began at the College of Nurses of Ontario in 1993, where I first discovered my love for nursing workforce research and other workforce research. So thank you for that. So I'm a big fan. We often, as Michelle indicated, have a lot of interaction with Congress or with legislators, and these are busy people. So I've developed this mode of summarizing my entire presentation in one slide. So if your phone rings, your dog barks, here's the gist of it. Our Carolina Health Workforce Research Center is based at the Shep Center. We are a health services research center at the University of North Carolina at Chapel Hill. As Michelle mentioned, we have been funded by HRSA. We've been funded for a decade to study emerging health workforce issues. I'm going to tell you a bit about our ultimate goal, which is to create what we call consumable morsels of evidence that inform health workforce policy. And over the course of the decade of research, it's hard to sort of put your research in buckets. But if I were asked to, I would say it falls into three general buckets. One, remember, we're the emerging topics center. So we're looking at the influence of evolving healthcare system delivery payment models on the healthcare workforce. We're also looking at team-based models of care. So how do interprofessional teams come together in integrated models of care? So integrated behavioral health and primary care, for example. I'm going to talk a bit about that. And then we're always interested in sort of monitoring the horizon. So what are those societal factors, those organizational level, hospital level, practice level, or professional level factors that are affecting how we train and sustain the workforce? So that's what our center does. So why is this important? This was from an article I wrote with a colleague from the National Health Service England. We were trying to conceptualize how you convince people why you want to do health workforce planning, right? And so I conceptualized this diagram, which really shows, you know, supply on the y-axis, time on the x-axis. And one of the things, at least we do here in the United States very well, is we lurch from oversupply to shortage. And the problem is, often we don't have the data, or we hadn't historically before these centers were funded, to understand that we were about to come into a shortage period. So you can see the ideal intervention point here is really acknowledging that maybe we're seeing a shortage. And this is something we've been able to do with the nursing workforce here in the United States. But typically we would wait till we get to the bottom of the curve and everyone would scream shortage. And then everyone, in a fragmented, completely uncoordinated way, would start opening programs and producing interventions, and then we'd find ourselves again lurching to oversupply. And so the idea here being that if we can have great health workforce research centers that are producing data, listen, we're not going to remove this cycle, right? We know there will be some cycle where we're not in perfect equilibrium, but you can see if we can sort of lessen the severity of that shortage, and we can increase the time between cycles of shortage and surplus. That's what the data are really intended to do in a very sort of simplistic terms, is really help us plan better. Workforce data for planning and policy, as Michelle indicated, to really help policymakers understand what's coming down the pike. So one of the things that I think is really important for anyone who's been in this space, and we're very acknowledging of this, is, you know, how do you, it sounds very great conceptually, but how do you use data to shape policy in the shadow of politics? And this is based on a paper, you have the reference in the slide. And, you know, there is an understandable cynicism about the role of data and evidence in policy making. I acknowledge that. And we do face, I think, an increasing no-do gap between what we know and what we actually do with that information. And one could argue that that gap is even larger in the health workforce, right? Because this is a space where we have a lot of vested interests, whether they're professional interests, turf wars, payment issues, et cetera. And my phone only ever rings when I'm giving presentations, so excuse me. So, but, you know, in fact, these health workforce research centers have been integral in producing data, building relationships with policymakers, building that trust, inserting data into policy, as Michelle said. Our job is to produce that data that shapes the policymakers' understanding of workforce problems. And how do we do that? We do it by simply documenting these trends that require policy action, often just producing the data and getting it, as Kingdon would say, into the policy window in time is critically important. And that's what these health workforce research centers do. We spend a lot of time thinking about the audience for our work. So if we're talking to the legislature, that's one thing, or Congress. If we're talking to professional associations, if we're talking to the hospital association, thinking about how to frame research in different ways to different stakeholders in different contexts, different employment settings and professions. And we spend a lot of time doing that. So a given policy brief or manuscript or research could show up in very different ways. Basic science remains the same, but the way that we interpret the message, or that whether we use a 2-page policy brief with a map or whether we use a manuscript, depends on the audience. And our whole goal is to really identify these emerging workforce issues. This is our conceptual diagram of where our center, sits in terms of producing data and evidence. So the Carolina Health Workforce Research Center, the goal, you can see us in the middle, our job is to really do that horizon scanning to look at what these emerging health workforce topics are. They're changing payment delivery. We've talked about the effects, the ongoing effects of the pandemic and preparedness, addressing social risk and social determinants of health, diversity, equity. And we try to collect the data, analyze it, and disseminate it so that we can actually shape discussions. You can see on that right-hand side what Michelle was talking about. We're constantly monitoring what is out there, what does HHS need, what does Congress need, what do professions need, and trying to help them have the information they need to develop, train, and sustain what we call a workforce for health. And I use that term very specifically. People talk about a health workforce. We talk about a workforce for health, and that includes professions that may typically not have been thought of as in the health workforce. We do a lot of work in social work, for example, and others who may not traditionally have been considered in the health workforce. So that's sort of our conceptual model. Now, here's those three buckets that I just mentioned, and I can talk about those again, but basically what we're trying to do is draw on new data sets. And one of the things we try really hard in our center to do is develop new methods for figuring out how to analyze the data. And a lot of these may be everything from developing methods around geospatial analysis, using latent class analysis, using new methods to really understand data and understand workforce. And then we, as Michelle indicated, a lot of what our center does is develop data visualizations. But a big piece of what our center tries to do is train the next generation of health workforce researchers, because that's critical in all of this. So I'm going to talk about each of these areas individually very quickly. So we have done, what I'm showing you here is a number of papers where we've tried to give you concrete examples of how we've tackled issues around the influence of evolving health system delivery and payment models. So back in 2015, we're looking at value-based care models and looking at the workforce transformations needed to staff value-based care models, and all these papers are on our website. We looked at the role of physician assistants and nurse practitioners in patient-centered medical homes in the United States. We are very diverse, and actually we're looking at, for example, partnering with some physical therapist colleagues. A lot of physical therapy had traditionally been focused in workforce on the acute care setting. Increasingly, it was shifting outpatient. So we were looking at the use of physical and occupational therapy after stroke in outpatient, and really showing addressing outpatient physical therapy needs reduce the risk of hospital readmission. Another study that I really love is a study we did. We asked medical assistants and family medicine physicians independently how they viewed the medical assistant role. And we have a paper here that really highlights sort of how the MA saw their role in primary care versus how the family medicine physician. And there's a lot of concordance, but there are really interesting areas where the MA thought they could do more, particularly around population health needs of the population. So that's our sort of first area, and just some sample manuscripts. Another thing that our team spends a lot of time thinking about is interprofessional teams in primary care and integrated care models. So here we've had a long history of trying to understand the role of social workers in integrated primary care behavioral health. I'm really lucky that co-director or deputy director of our center is a social worker. Really trying to understand. No one had actually ever really gone in and understood and studied, what is it that social workers actually do in integrated behavioral health settings in primary care? What is their role? How do they interface with the team? How do we train students to do these things? So we've been doing a lot of work in that area. We've also been doing some work looking at the roles of pharmacists embedded on primary care teams and the ways that pharmacists actually address medication management and actually improve primary care. And this was a study that we looked at the geographic distribution of co-location to really understand those places where we had co-located teams and those places that we did not. And the last place, just briefly, I'll talk about is we've done a lot of work on organizational, professional, and societal factors. Here, I don't have time to tell you all that we've done a lot of work on burnout and workforce well-being. But here, I just want to highlight two studies we've done looking at graduate medical education in the United States. We have Medicaid, which is one of our payers in the United States, which tends to pay lower income people and some people with disabilities. And in fact, even though Medicare, which is our insurance for people over the age of 65, Medicare pays about $20 billion annually for graduate medical education. Little known fact that Medicaid actually is up to $7.39 billion itself. So there's separate funding stream. So this is a study that's really helping. Medicaid is controlled by states. It is a joint federal state partnership, but the states can actually use Medicaid dollars to fund graduate medical education, and they have increasingly. And this is a study where we used states as policy laboratories to understand what they were doing and how they were expanding graduate medical education. One of my favorite projects is DocFlows over here. You can access it through our website. This was a fun study we did where we took the American Medical Association master file to look at where physicians were moving. A lot of migration between states in the United States. So no state is an island, right? It's dependent on other states, both for importing and it also exports. So DocFlows shows you the importing and exporting of not only physicians, but of trainees. And this is how Wyoming found out that Idaho was stealing all of its physicians, but that's for a story for another day. Our year 10 projects, this is just a brief overview of last year's projects. We were looking at the changing hospital workforce. You'll have these slides. The increased use of community health workers and really using 3 different data sets to understand, can we even enumerate the number of community health workers, right? And actually, it turns out 3 different data sets give you 3 different answers. We are looking at the social care workforce and investigating if skill mix composition at a community health center affects whether you're actually screened for social risk. So in what degree does the composition of the workforce affect what screening happens for social risk? Working with a sociologist colleague, looking at the factors shaping physician well-being. And really, this is an ethnographic study. So I didn't have a lot of time to talk. We do everything from hardcore econometric modeling to ethnography and using other methods. This is an ethnography asking physicians what it means to feel valued and how the organization might exact a toll on their health and well-being. We're also partnering with a colleague in pediatrics to look at the role of historically Black colleges and universities in increasing the number of Black physicians in medical schools and ultimately the physician workforce. Here in the United States, workplace violence was increasing before the pandemic and has only has more than doubled actually since the pandemic. And we're looking at using different data sets to really estimate the prevalence and incidence of workplace violence against different health occupations in different settings. So that just gives you a flavor of some of the projects from last year. I want to end with what I think is incredibly important. It's not just about the data, it's how we communicate the findings from the data. And I think one of the things that our center has learned over the past decade is really working to do exactly what this quote says, is more can be done to expand the scope of consumable morsels of evidence, to house them in accessible archives, to make sure those with policymaking authority know where to look and access this information as they need it, without nursing any delusional expectations of creating a new world of evidence-driven policymaking. So here you have a humble but optimistic view of how we can use data to shape health workforce policy. And I'm going to turn it over to my colleague, Bianca Frogner. But before that, I just want to say very briefly that the fact that we've had 10 years of funding has made a huge difference. We're incredibly grateful. These are competitive grants. We do apply for them, cooperative agreements. We're so grateful that one of the things that you see is that over the course of that decade, we've built, with funding from NCWA, a set of centers who've been able to inform. We compete with each other, but we're also a peer network and we make each other's work better. We peer review each other's work. We serve as each other's sort of best advisors. And that kind of network in a country, is incredibly important to build strengths because each person has different strengths. And so I want to turn it over to Bianca to share with you the work happening at her center. Thanks very much.
Thank you so much, Erin. So great to be here. And I think Michelle and Erin did a wonderful job setting me up. I'm just going to pull up my screen here. So just give me a second. Okay, hopefully you see my presentation in the regular presenter mode. Please let me know if you see it otherwise. So I'm Bianca Frogner. I'm a professor in the Department of Family Medicine also. I'm at the University of Washington. Similar to Erin, my background, though, is not as a clinician. I'm a health services researcher and health economist who happens to sit in the Department of Family Medicine. And just so you know, it's not the case that all of these centers sit in schools of medicine. These centers do certainly sit in schools of public health. as well as other schools. So it just happens to be that Erin and I happen to be these two examples of health services researchers in family medicine departments in the US, where they have fairly robust research groups. And I think that's what's allowed our center in particular to thrive.
Bianca, it's
yeah.
Erin here. Sorry, we are seeing your notes
Oh,
pages,
sorry.
not your presenter
Okay.
mode, just so you're
All right,
aware.
I will switch.
This is our other role as
There we
sister
go.
centers to advise each other on technical details.
Appreciate that. Is that better? Did that change things now?
Yep, better. Thanks.
Yes. Okay, perfect. Thank you. Thank you for that. And so I also direct the Center for Health Workforce Studies. I've been here I'm getting close to 10 years now, but I came here to direct a center that had already been well established in the department for now 25 years. This is our 25th year of being a center. And I'll say that HRSA is actually one of the reasons why the center came to existence 25 years ago. So it really was an important part of establishing this presence at the University of Washington. And I'm going to refer to our center as CHOOSE because that is how we tend to refer to ourselves. So if you hear me say that, just know that I'm talking about the Center for Health Workforce Studies. So our center certainly relies on and is very grateful for HRSA funding as something that has been a core of a lot of the work we do. However, we do have funding from a number of other sources, and especially from our state. We work very closely with our state legislators and other state stakeholders and partners to conduct health workforce research that it tends to be more state focused or regionally focused. And this work is becoming a fairly big growing portfolio of funds. And there's some nice synergies between the national work we do with our HRSA grants and the state work that we do. And there's just a lot of back and forth between the topics that we do, the kinds of sharing of survey instruments that we can do between state and national levels. And I think we tend to find a lot of the things that we struggle with here in the state of Washington to be similar to things that people are struggling with nationally. Our work, certainly much like how Erin described it, our work is aiming towards trying to inform health workforce planners, both here in the state and nationally. And we do our best to try to communicate with our local and national policymakers, whether it be in person, online, in this remote hybrid kind of a format. We certainly make use of all the tools available that we can. I will say that with kind of Twitter switching itself over to X.com or whatever we're calling it these days, I think there's a little bit of a question about how to best communicate with folks, and especially policymakers and news outlets in an online format where lots of people used to be spending time before. So I'm going to talk a little bit more about our two HRSA specific centers. Michelle alluded to, and so did Erin allude to the fact that University of Washington has two centers. I am the PI of both of these centers, and we can certainly go into kind of whether that's how that came to be, but I am certainly not doing this alone. I am fortunate to have a wonderful group of folks behind me, including our Deputy Director, Sue Skillman for the Allied Health portfolio of work, and Davis Patterson for the Health Equity portfolio of work. Sue Skillman is also the Senior Deputy Director of the Center for Health Workforce Studies. So she oversees and supports much of the larger programs that we have in CHOOSE. Michelle gave a little bit of a history of the centers. And so the Allied Health Center came to be at UW starting in 2014. Health Equity became a newer center online in 2018. And so we've been fortunate to have this longevity in both portfolios of funding, where we're now in year 10 for the Allied Health Center versus Erin's center is actually in year 11 because they started 1 year before us. And now we're entering year 6 in our Health Equity portfolio. We're very grateful to have these years of work because it does allow us to have this continuity of work, as alluded to by Erin. Now I'll dig a little bit more into our allied health portfolio and give you a little sense of what kind of drives us rather than going into too much of our topics. I'll say allied health is a term that I think is one that we could have a whole discussion on in and of itself. But generally, when we think about allied health and who we're talking about, we are really thinking about a broad spectrum of workers in the health workforce. But generally, it does not include doctors, nurses, or dentists. Just to emphasize that point, in the US, our healthcare industry employs approximately 17 million people. A lot of the interests of our center tends to go to the healthcare support workers in our healthcare industry. So that could be your medical assistants, your nursing assistants, your home health aides, pharmacy aides, et cetera. And that is about 1 in 4 of the people who work in healthcare. We also care very much about another group of usually kind of advanced practice, high level educated workers, including pharmacists, your physical therapists, clinical lab workers. So we do look at a real broad variety of workers. We also do include in our portfolio of work licensed practical nurses, licensed vocational nurses, which is a small portion, but a meaningful group and tends to be excluded from other nursing studies. We do think a lot about a variety of settings, whether it be your hospitals, which is about 1/3 of our industry, outpatient settings, or ambulatory care settings, which is another 1/3, or your long-term care settings, which is the other 1/3 of the pie. And a lot of the times we try to emphasize this point that our workers are working across multiple settings, because oftentimes, and probably prior to the centers coming to be, a lot of the health workforce research that existed really focused on hospitals, it focused on nurses, it focused on doctors. So our aim is really to broaden that lens and just help with the educational process of identifying the very large sector that healthcare is, and to help identify the nuances of where people are working. I'm a health economist, so I like to talk about supply and demand. I'm not going to show you a typical supply and demand graph, but I will say that the tension that we're often trying to address is this balance between supply and demand. And probably a better visual is thinking about the seesaw and how it's constantly ebb and a flow between these two groups, much similar to Erin's sinusoidal wave that she had earlier, is that there really is this back and forth balance between these two sides. We tend to focus in our work on the labor supply part, in terms of figuring out how many people we have in the workforce, what do they look like, how do we get more of them. But the employer side of the piece is also very important, trying to identify and connect the dots between the people who work in healthcare and the actual patient need is critical. Where I think policymakers really want to hear from us, and where we try to bring out some important lessons learned, is that wedge piece, which is what tips that balance between the supply and the demand. And that can be actual wages, new technologies, the distribution of our workers, and policies, whether they be organizational policies or national policies. And a lot of our work in our Allied Health Center does try to identify barriers to the supply side of the puzzle. So these are just some examples of some challenges to the supply of our workforce. And in the blue font is some of the solutions or some of the approaches to addressing these supply barriers. And these tend to be many of the themes that come across in our work, is to identify what those barriers are, and then simultaneously also identify what some facilitators are to solving those barriers. So broadly, our allied health portfolio's common themes tend to be things like highlighting lesser known occupations, like the clinical lab workforce, for example. There's a lot of workers in that group. So just saying clinical lab workers is not sufficient. So we're trying to bring out the histotechnicians, histotechnologists, phlebotomists, medical lab scientists, and try to unpack who are they? What do they do? How many people do we even have of these workers? We do think a lot about those lower wage workers, those wage workers with lower levels of education, and highlight their roles and the importance of their roles, and then think about the career pathways that they may or may not be having access to. And it's not always a linear path, but it can also be a lattice where people are moving left and right, up and down. We're trying to highlight the complexities of those career paths that many workers face. In our upcoming year, this is just a snapshot of the titles of our of the studies that we're planning to do in this upcoming year, just to give you a flavor of the kinds of work that we're doing. Wherever possible, we do try to build on prior work, and that's a great part about having the longevity of this center, is that each year we have to finish a study, but by having multiple years, we can then think of these studies as like a part 1 and a part 2 and build to bigger studies. And a lot of times I do think of this as sometimes pilot work that can also be spun off into larger projects. For example, that last project listed there, we've had some nice synergies with our Department of Rehabilitation Medicine colleagues who have gone off to get NIH R01 grants, which have been in part really supported by some of the work that HRSA has funded via our Allied Health Center. So that's been a really fruitful relationship. Now, I'll just go through our health equity work, which was funded and started in 2018. In our health equity work, we could again have a whole discussion on what is health equity exactly. In this portfolio of work, we do address all occupations. So doctors, nurses, and dentists come back into our portfolio of work. And we try to take a really broad view of health equity, recognizing that there are many dimensions to equity and diversity. That's not just simply about race or ethnicity. It's not just about sexual orientation, but it's also about the intersection between those two. It's about the geographic disparities that we see in our health workforce as well as in our patient care, both of which are very tied together. We like to bring out the importance of disabilities among our healthcare workers themselves, the language concordance between patients and providers. So we try wherever possible to look at intersections, but at a most basic level, we just try to highlight the fact that there are many dimensions of diversity that we need to think about that then translate to patient care. And there's a couple of frameworks that help drive our thinking around the connection between what's happening in the workforce and what that means for achieving health equity in the patient population. And this is just a framework that I pulled out and commonly used that was published in Public Health Reports about 10 years ago now, where they argue why it is important to increase workforce diversity as a way to achieve health equity, and that by increasing the workforce diversity, we will maybe improve access and quality of care delivered to patients. This in turn may help reduce health disparities and ultimately achieve health equity. Now, we know that that picture is much more complicated. The goal here is not for you to understand and see every piece of this, but it's just to unpack that pathway between increasing the workforce diversity and achieving health equity is complex and takes many steps. Even further, we do recognize that there are workers already in place in the workforce, and that some folks may have received their education many years ago, and that continuing education is important. So another guiding framework for our work is the National Academies framework that was developed in 2016 on thinking about how to help educate health professionals to address the social determinants of health, which are critical for improving health equity. So this is just another framework I just point you all to help and guide your own discussions about how to think about health equity as it relates to the health workforce. Common themes in our workforce, in our health equity portfolio, is thinking about the diversity of the workforce and thinking about the role of healthcare workers in addressing health equity, as well as thinking about health equity training for health professionals. And here again are our upcoming studies that we're doing this year, again, kind of highlighting those various themes, as I mentioned. And I just wanted to highlight that a lot of our work can't be done without amazing data. And data are certainly hard to come by, as many of you are probably aware of yourself. And one of the major collectors of data that is so critical for us is the US government. They collect wonderful public data that aren't necessarily health workforce specific data. We have the American Community Survey, which is basically the long form of the US Census. And this is collected annually on a sample of about 3 million people, about 1 million households. And this provides really important demographic information about our healthcare workers, as well as geographic distribution data. We have a current population survey, which is a monthly household survey that provides details on wages and income and other employment characteristics. In addition to that, HRSA has been a champion in getting large national scale surveys accomplished. A very important one is the National Sample Survey of Registered Nurses. And this work then has been funded via our subsequent research of using this survey has been funded via our health workforce research centers, which has been very helpful. Through our HRSA grants, we've been able to develop new surveys in-house. We also partner with other entities and use proprietary data. We do a lot of qualitative work, whether it be interviews, analyzing open text responses, and we do a number of landscape and literature reviews. I certainly encourage you all to check out our website. We have a specific section of our website focused on the Health Workforce Research Centers. And as before, here are the links to all of our wonderful partners, which has been so important as part of our process, because who Erin's training oftentimes become people that we end up working with, and vice versa. And so we're all in this together. It is a small but mighty community, and I'm incredibly grateful for HRSA's support to get us here. So thank you. I'm going to turn it back to Ivy.
Thank you so much, Bianca, Erin, and Michelle. Absolutely wonderful information about the National Centers for Health Workforce Studies, the CHOOS, in the U.S. And I want to encourage everybody to pose your questions either in the chat, or if you'd like to use the raise hand option and just unmute. And it's also very nice for folks to see if you're posing a question to put your cameras on. And so while people are posting things into the chat, I have posed some specific questions to each of you, but also have one general question for you to consider while you're also thinking about your specific question. And it's really about what would you say are the most promising elements of the program and the centers that Canada could strongly consider emulating? So that's a generic question. The specific question for Michelle is, I'm curious about how your funding of the extramural research intersects with NIH funding or not, as the case may be. And maybe we'll go with that question, Michelle, while Erin and Bianca sort of contemplate the general one, but we're happy to have your response to the general question as well. So Michelle.
Sure. So I think there, you know, to your question about what Canada can take away from our structure, I think that over time, once the National Center was codified in the Affordable Care Act, because there actually had been a National Center prior to that, it just was not legislatively mandated. It was done with discretionary funds. So it's not like everything that the three of us are talking about in terms of structure and infrastructure started in 2013. It did not. There were precursors. It's just that the Affordable Care Act put it into statute and then forced Congress to actually appropriate dedicated funding for this. What has happened over the course of the past decade is that we have very distinctive roles that really don't overlap. And there's a benefit to the US for having both of those structures. The National Center, our scope is broader or different, I guess I should say, than what the HWRCs do. The HWRCs, through these cooperative agreements, and by leveraging other funding out there, are able to do things we cannot. They are able to move at a faster pace. They can research issues that if a particular administration is in the White House and they don't want it researched, they can. I can't maybe do it with our funding, but they have license to do so. The other thing is that with a national center, we have access to things that they do not have. We have access to, Erin was talking about Medicare and Medicaid, you know, the largest healthcare payers in the US. So we have access because of our protections and our role as the federal government to data that maybe cannot be shared outside of the federal government. We have access to just different channels, I guess I would say. The other thing we do, and this sort of leads up to your question about NIH, is that because we are the federal government and the HWRCs do that, like Bianca has mentioned, being so successful, leveraging other funding, we do the same internally. So I have colleagues at the Centers for Disease Prevention and Control. We get funding from them. Our Substance Abuse Mental Health Administration gives us money. We then turn it around. A lot of that does go to the HWRCs, but I actually take some of that funding internally and we use it to produce other things independent of this particular program, this extramural research program. The other thing is that oftentimes, let's be honest, in the US, the federal government it takes a certain, when we come out with a statement or something, there's a certain amount of clout to it. And maybe clout's not the right word. It's just taken at a certain level of, this is the federal government. This is sort of the underlying period at the end of the sentence. That's not the same as something that, say, Erin or Bianca put in front of the National Academies of Science or have in a peer-reviewed article. They're both equally kind of important, but different. So I think we've created it's good structure and a very nice relationship, for a national, federally mandated organization to have the HRSAs are not simply an extension of what we do, and nor are we just a pass-through of funding for them. It's really a symbiotic relationship, but we also have very different roles to play.
Excellent. Thank you so much, Michelle. There's actually a really great question from Margaret. Margaret, I'm just going to ask you to unmute because I think that it also addresses this overarching issue. And I think both Erin and Bianca could respond to that. So Margaret?
Sure, yeah, I put my question in the chat. Thank you so much for your presentation. So impressive and inspiring. I think part of the question was just answered by Michelle. So I was interested in how many of these centres predated effectively the codification in the Affordable Care Act, how many of them emerged as a response, but then also kind of thinking about, political change that might occur and whether you feel like it could have a disruptive effect to what all your centres do and the kind of work that you've already done, or do you feel that this has already become embedded enough that policymakers from both sides of the House and across the sort of federal system really couldn't see going forward without it? I just wonder if you have a thought about that.
I have a lot of thoughts, but I'm sure Bianca and Erin want to weigh in too. But mine would be that we have been, since the passage of the Affordable Care Act, we have been funded by congressional majorities from both sides of the aisle. It has been, in that sense, a non-controversial issue. And yes, while administrations will come in and one may say, we don't want to fund research on, say, abortion, and another one may say, we don't want to fund research on this or that. That's like a small piece of it, because these are cooperative agreements again, and not contracts and not grants. We have a say, but we ultimately don't 100% control what, for example, Bianca and Erin are researching.
Yeah, I'll jump in here. I think that's incredibly important. And when Ivy asked about what we thought, might be important to emulate, I do think this cooperative agreement mode is really important, because it just to echo what Michelle said from the other side, what it really does help is us define what are the priorities and sort of negotiate the work that we're going to do to make sure that our work is really relevant to what's happening to policymakers. And truthfully, Margaret, that does change, right? But good workforce research is relevant to both sides. But in fact, it does. The agenda does change and maybe should change. So maybe this administration is more interested in a particular workforce or a particular topic. Having the health workforce research centers poised and ready to produce that information, make sure that they're actually using data instead of anecdote. And the other thing about putting these things and funding them in a sustainable way is that when the pandemic hit, the workforce research centers were all already in place. And I can remember having multiple meetings among our group going, who are we responding to? What do you need? Hey, Washington. So it was both at the federal level, we were able to help Michelle and colleagues at HRSA, but between our centers, we were able to say, Bianca, what are you looking at University of Washington? Oh, Joanne, I'll take that staffing model that you developed. Oh, here's what we're doing in North Carolina. So there is this having something in place rather than thinking that the minute the government changes, administration has this huge workforce question and nobody has any data analyzed or ready, I think is important. I also want to echo, as someone who has irritated policymakers as equally as I've tried to please them, I think having a role in academia outside of the government, speaking truth to power, is incredibly important. We are free to say what we want. We try to do so with diplomacy, try very hard, and in a way that it will be heard, but we are often able to speak about the uncomfortable truths in the healthcare workforce. And if you speak about these uncomfortable truths often enough, people begin to understand them in a different way, and you framed their understanding of the issue. And so I want to say that's also really powerful, is that we can say things that Michelle cannot say. And so those are some of the things that I think from our center's perspective, we've actually had, to answer your other question, we were actually funded in the early 2000s before this was codified in the Affordable Care Act. So our center has been around, and then we lost funding, and then we came back and competed for funding. So.
And maybe I'll touch on a couple of these same points. So just building off the last point of Erin's, is that, you know, and your question, Margaret, is that I would say about half of the centers, or more or less, had some entity before this Health Workforce Research Center reemerged, some of which started because there was HRSA funding some decades ago. But as Erin just pointed out, we have lost funding too. So it certainly has stressed the importance of having a diverse portfolio of work. Now, I will say that a number of new universities kind of, I would say, popped up onto the health workforce scene, but not really, because there were like one or two main experts in health workforce, for example, at George Washington University. And I'll use that as an example because that's actually where I started my academic career, is there. And there wasn't like a formal center, but we had big powerhouse researchers like Fitzhugh Mullen, Polly Pittman. They were already doing work in this area. And when the HRSA, and they did it with a number of different kinds of granting mechanisms. And when the Health Workforce Research Program came together, it gave us something to coalesce around, and gave persons like me, who is an emerging kind of researcher in this space, a chance to kind of latch on, take on some projects. And then that really set me up to come over here to University of Washington. And again, that's why I say, like, you know, a trainee at one place kind of ends up being maybe another place. We certainly have seen this. I don't think I'm the only example of this so far. It is, I think, an important part of this also being a mechanism that sits with academic societies, and to some degree, is that there is this communal aspect to these grants, that HRSA is kind of convening us together, but gives us the flexibility to be academics as we are. It gives us this balance between wanting to study things for long periods of time, but with short turnaround periods. That's an interesting mechanism, right? We have the protection of like now 5 years of funding, but we are having to be responsive on a year-to-year basis. So finding that balance, I think, is important, because otherwise we could just kind of sit there and do research for a long time, never be responsive to anything. So this forces us to be that way. But I would say the other thing is the topic areas that HRSA has picked is also very purposeful, I'm guessing. I don't know all the history behind the choices of it, but what I have appreciated about it is that it's not very specific to an occupation. It's more theme-based, and that gives a lot more flexibility to think creatively about all the different kinds of workers that might be existing in these various spaces. And that allows us to think more team-based. And I really appreciate that nuance, and the fact that it's trying to shed light on places that don't often get talked about. And I'll say, as a health equity center, I am concerned sometimes about what the federal government or national politics kind of tend to be around topics like that. I did see a question earlier from Victoria, though I think it got deleted, around kind of gender inequities and thinking about gender as a topic or race as a topic. And I think, again, that's where intersectionality can be very important, is that we talk about the importance of all the different dimensions of equity and how they intersect together. And I think framing is a key part of what we're doing. And these are topics that are going to be long-lived topics. So we have to be delicate, maybe sometimes, about the politics at play. And I think HRSA certainly faces that more than we do as academics.
Can I just quickly,
Yep.
sorry, follow up. Thank you so much for your answers. And it did make me think, I'm thinking about how we might emulate this in Canada with talk about a national centre for excellence on health workforce, and thinking about the already existing research capacities that's out there, and how can we kind of join them up under an umbrella. And I'm thinking we did do this some years ago on the issue of immigration. We had the metropolis centres. It was federally funded. The centres were spread across the country. It was funded for 15 years and beyond. And then the funding kind of stopped. But we did build capacity in that field, and we built connections. And so I do think your model is so fascinating, and something really for us to examine and consider in the Canadian context. So thanks so much for your answers.
Thank you so much, Margaret. And I want to thank all of the speakers, Michelle, Erin, and Bianca. What an amazing event. We're looking forward to following up with you. If anybody else has any other questions that you'd like us to pose, to our speakers today on your behalf. We can get those responses later. But a big, electronic applause for amazing presentations, very high quality, great promising practices that hopefully we will beg, borrow, and steal from you as we develop the Center for Excellence. So thanks, everybody. Have a great afternoon, and looking forward to seeing you at our next webinar. Take care.